Yes, sir.
Okay, so I was telling you that we discussed already about the general principle of chemotherapy, and we also discussed quickly about the drugs that are used in cancer. But today we'll discuss about a particular cancer, that is a breast cancer. And this is going to be again a major chapter from your exam point of view as well. So you need to go very thoroughly with this also. So let's start. Okay, so at the end of the chapter, this I will be teaching from this. This is the PDF from the TPRO, the standard textbook that you guys are supposed to follow. So at the end, at the beginning of each chapter in the DPRO, if you have noted, there will be these key concepts. Okay, so at the end of this chapter, you need to understand these 10 key concepts from this chapter. From this chapter, so I will quickly read through this. I'll quickly tell you what are these 10 key points. The first one is that breast cancer is usually diagnosed in early stage and it is highly curable in that stage. We have a local therapy for early stage breast cancer, like mastectomy. I will tell you what is mastectomy, what is leucectomy, and also external beam radiation, depending on what stage the cancer is, the breast cancer is. We have adjuvant therapy, adjuvant endocrine therapy, and this is what we had discussed in general principle of chemotherapy. What is adjuvant? What is neoadjuvant? So we have adjuvant endocrine therapy that reduces the relapse and death in many breast cancer patients who have hormone receptor positive breast cancer. Okay. And then the fourth point you need to understand is that the choice of chemotherapy regimen that we'll be using depends on many factors, and there depends on many factors and many things in the choosing of this endocrine therapy, or in the like choosing chemotherapy in the breast cancer is very controversial. Okay, this is one thing that we're going to see repeatedly in this chapter, that whatever some people will be telling one opinion, other people will be telling different opinion, and finally we end up with the conclusion that it still needs more research and more information to conclude one particular thing. So we'll see still what are those one opinion, what are those other opinion. Um, then fifth point you need to understand is neoadjuvant chemotherapy is appropriate for patient with locally advanced or inflammatory breast cancer. Then you also need to understand that initial therapy of metastatic breast cancer. You are seeing I'm using the word here, locally advanced and metastatic breast cancer. Again, these are the types of breast cancer based on the stage, based on the extent. So we'll discuss that in detail in this chapter. So for metastatic breast cancer, we have whoever have metastatic breast cancer, and if the patient have hormone receptor positive tumor, then they respond much better with the drugs that act by hormonal manipulation. And approximately 40% of the patient, 40% of the women who have metastatic breast cancer respond to chemotherapy regimen, that is anthracycline and taxane containing regimen. Okay, so almost 40% of the metastatic breast cancer. I will talk what is metastatic breast cancer. And the goal of the adjuvant therapy is curative. Okay, whereas goal of chemotherapy in the metastatic setting is palliative, because metastatic is a little bit a later stage, so we cannot target much in that. So that the goal of the treatment is palliative than the curative, but the goal of the adjuvant chemotherapy is curative. So though we have many controversial things, like when how frequently the screening or the mammography should be done in the women, and with what age, whether it is like from what age they should start and till what age they should keep going on, keep doing on. So all those things we are going to discuss in this chapter. Okay. So we are going to discuss epidemiology, we are going to discuss the etiology, we are going to discuss a little bit about clinical manifestation, then diagnosis, and then how it can be treated, what are the treatment modalities that we have available for breast cancer. Okay. Yeah, so this is just an overview that I gave for this chapter. So now I'm diving in the introduction part. Is this clear? Okay. This is just the overview. Okay. Am I audible clearly?
Yes,
Yes,
sir.
sir.
Yes.
Okay.
Yes, sir.
So breast cancer is the most common site of cancer, and this is the second. The first one is lung cancer. Lung cancer as the cause of death in American women. Second, after that, lung cancer. Second is the breast cancer, the most common cause of death in the American women. Okay, and female breast cancer incidence rates vary considerably across race. Again, there are this thing, racial and ethnic group based on whether the white, whether the population is black. Based on that, also the breast cancer does vary, and female breast cancer incidence rates have increased since in the last um, 3 to 4 decades. The incidence rate has increased. I will show you a graph over here. If I talk about ethnic, you can see here. Can you see this graph? See, this x-axis is the year of diagnosis. The y-axis is the rate incidence rate. Okay, so this you have two lines here. So one line is for white, this light color. This red, dark red color is for black. Okay, so if you see the um, incidence rate of the disease in whites and black, the whites are having more as the year has passed by. The whites are having more of breast cancer, isn't it? The incidence rate. I'm asking you to look at this line right now. But whereas if you see the mortality, as the year has passed by, you see though the black have less incidence, but the black have more mortality as the year have passed, isn't it? So this is the just general incidence of breast cancer and mortality rate by race. Okay, if you see by race or ethnic. So this incidence, why this? I was telling since last 3 to 4 decades, the incidence has increased. There can be many reasons that you can give for this increase in incidence. One of them could be like increased use of screening mammography. They increased use of like they got more aware about this disease. They started more of screening and reported more like we have now for COVID-19. Initially, we had less diagnostic kit, and therefore the reported cases were less, the incidents were less. But now, as the diagnostic kit are being developed more in more number by different company, the reporting rate is increasing, the incidence is increasing. Similar might be the case here. Since last 3 to 4 decades, the screening mammography has increased, and that might have caused this increase that we saw in the graph. And also the use of post-menopausal hormonal replacement therapy. So this is something I think you read last year, therapeutics, am I right? Pharmacotherapeutics 1, hormone replacement therapy.
Yes, sir.
Yeah, so why do we use that, Julissa? What is hormonal replacement therapy?
By giving hormones and for treating that.
Okay, for what purpose? What is the indication of hormonal replacement therapy? Yes, Mahesh? Rasmi? Rajan? What is the indication of hormonal replacement therapy, also called as HRT? Ravi?
So to balance the hormones after the menopause and also.
Yeah, see, after the post-menopause, the most of the women will have post-menopausal syndrome. We call it as post-menopausal syndrome, and this happens, as he said rightly, that because of imbalance in hormone, that they will have these symptoms like hot flashes, mood swings, many kind of headache, all those kind of symptoms. So, and even the bone problem, any kind of bone problem like osteoporosis and all. So to sort out that, this the HRT is one of the indications for those kind of problems. So this use of hormone replacement therapy, okay, makes the patient prone to get cancer, breast cancer. Okay, so we'll discuss in the etiology how does that happen. Mm, Okay, so the median age for the diagnosis, we look at the age of the diagnosis of breast cancer. The median age is between 60 and 65 years. So, and this is one of the interesting fact I was talking in the beginning of this introduction, that lung cancer is one of the leading cause of death for women. Um, if you see of any age, I told you the breast cancer is a second, okay, after the lung cancer. If you see in any age, okay, any age, of course, the data that I gave you, the lung cancer is the number one, and the breast cancer is the number two. Okay, but if you see for particular age between 20 to 59 years, okay, breast cancer is the leading cause of cancer death for the female. Okay, not the lung cancer. So still the morbidity and the mortality is still more of the breast cancer in this particular age group. That's what is the point here. So coming to epidemiology and etiology, this was a brief introduction. So the two variable most strongly, just give me a second. Okay, the two variable most strongly associated with the occurrence of breast cancer are gender and age. When I talk about gender and age, okay, when I talk about breast cancer, you think of female, right? Female are supposed to get a breast cancer, but it's not always that case. Okay, the male can also have breast cancer. If you see the incidence rate, around 2030 cases of male breast cancer. It was projected that in an year of 2007, around 2030 cases of male breast cancer will be diagnosed. So it's not that of course, yes, female are more prone to get breast cancer, but it's not like only female have chances and male cannot get the breast cancer. So that's one part, gender. Okay, and the next part is age. Okay. But again, male cancer is treated in the same way, with the same therapeutic modality that we have for the female breast cancer. Then the age part, the incidence of breast cancer actually increases with advancing age, and the frequently quoted breast cancer static is that 1 in 8 women will develop breast cancer during their lifetime. So it's like as the age increases, the breast cancer, here this table 131.1, you can see the risks of developing breast cancer according to the age. Okay, so this is a probability of developing invasive breast cancer during the interval. So if you see 30 to 40 years, the probability is 0.43 or 1 in 233. If you see age 40 to 50 years, then 1 in 69. 50 to 60 year is 1 in 38. Okay, so this denominator is decreasing and this one remains constant. That means the risk is increasing as the age increases, isn't it? This is 1 in 27 for 60 to 70 year, 1 in 27. So that's quite high. Okay, so as the age increases, the risk is increasing. That's what is the moral of this two factor. Okay, we have some of the assessment tool to assess the risk. Okay, the National Cancer Institute has online version of this breast cancer risk assessment tool, which can be accessed from this www.cancer.gov /BCR BC breast cancer BC for breast BC risk tool dot /default.asps. If you go to this link, you will have this is a tool, okay, risk assessment tool. You need to give some data there, and then it will help you to assess the risk. But again, there are some controversial telling that we have some more other way to assess the risk. This risk assessment tool also have some of the limitation, like it doesn't keep in account of ethnicity, races, all those things. But there are some that can help us to assess the risk. Okay, so we are diving into the etiology from the epidemiology. Okay, so in the etiology, one of the etiology is endocrine factor, very much important reason for breast cancer. So you know that there are many hormonal changes in the woman life, right from menarche to menopause, and in between that, the puberty, the during the pregnancy, post delivery, antenatal. So many changes happen, okay, during the menstrual life, and even pre menarche and post menopause. So we'll see what are the endocrine factors that are the major causes of breast cancer. So early menarche, okay, I hope you know what is menarche. The beginning of the menstruation cycle, the beginning of first menstruation cycle, the beginning of the menstruation cycle. So if it is said that if it is before age of 12 years. Okay, if it is before age of 12 years, that's early menarche, then there is a cumulative lifetime risk of breast cancer development. Okay, so, and again they say if there is a late age for natural menopause, okay, maybe after 55 years, then there is again increased risk of getting breast cancer. Is it clear? Early menarche and late menopause, late natural menopause. It also said that if the patient have bilateral oophorectomy, okay, if the patient have bilateral oophorectomy, if the patient have bilateral oophorectomy prior to the age of 40 years, oophorectomy is the removal of ovaries. Okay, bilateral means both. If the female have undergone bilateral oophorectomy before the age of 40 years, that reduces the risk of developing breast cancer. That reduces because there is no hormone, because ovaries are responsible for producing all this hormone. So these were some of the endocrine factor. Apart from this, we are still going to discuss the first endocrine factor. I tell you that if there is early menarche, that is before the age of 12, if there is late natural menopause, that is after the age of 55 years, then there is increased risk of getting breast cancer. If there is if the patient has gone bilateral oophorectomy, that is the removal of both ovary, then that if this has happened, or the patient has undergone before the age of 40 years, the relative risk is low for getting the breast cancer. Okay, these 3 point I told you. Next is nulliparity. What do you know? What do you mean by nulliparity, Rasmi?
Don't know.
Okay, Swastika. Okay,
The condition in which the woman can never give birth or something like that.
Yeah, correct. So I think when you go OBG, you see they write G for gravid, P for parity, L for live birth. Have you ever noted that? So this parity means how many times the patient have become pregnant, women have become pregnant. Null means zero. So if now many times maybe because of physiological condition, or maybe because of pathological condition, um, the woman doesn't conceive. Okay, they cannot conceive, and they cannot give birth, and they cannot become pregnant. So that's a nulliparity. Okay, so if there is nulliparity, that increases the chance of getting breast cancer as well. Okay, or now the trend is increasing, like the female patient doesn't get the female lady doesn't get married even till late like 35 years of age as well. So even this increases the risk of um, actually breast cancer. Okay, so first birth if the first birth of baby is after the 30 years of a female, so that again have been reported as increased risk of getting a breast cancer. Okay, so these are some of the risk factor related to endocrine. Okay, and I was telling as I was talking about hormone replacement therapy, that is nothing but exogenous hormone. Okay, so even this many studies have evaluated the relationship between this hormone replacement therapy and development of breast cancer, and they have found some positive evidence supporting that. The use of post menopausal hormone replacement therapy in women with a history of breast cancer is generally contraindicated. So if the patient have that's what the HRT make the patient predisposed to get breast cancer. So if there is if the physician is thinking of using HRT in a woman who have breast cancer, history of breast cancer, so that's not the correct way to go with the treatment. Okay, so because this can make the relapse to happen again for the breast cancer. So the reason is, again, there is strong association of estrogen and risk of breast cancer. Risk of breast cancer. Okay, so this was a brief about hormonal. So just keep noting the point, whatever I'm talking about, endocrine factor. Okay, so we discussed about menopause, we discussed about menstrual life, we discussed about nulliparity, we discussed about late age giving the first birth, we discussed about SRT, okay, in the endocrine factors. And then I'll also emphasize that oral contraceptive, okay, because this is also nothing but a hormonal pill, isn't it? In your chapter last year, hormonal replacement therapy, you read oral contraceptive pill as well. So this is also nothing but a estrogen and progesterone combination. So, but again, against this, there we have many conflicting evidence, many contradictory evidences, which says that um, this contains very low dose of oral contraceptives, and there is not much, if you can compare the risk benefit, there is not much risk. So oral contraceptives are known to reduce the ovarian and endometrial cancer, that is also said, okay. So there are kind of conflicting and contradictory um, points being made along with the oral contraceptive pills. So these were about the genetic factors, endocrine factors. Okay, what are the endocrine factors in the etiology that make the patient more predisposed to get a breast cancer? So now we'll be moving towards genetic factors. Genetic factors means if the patient family, in the patient family, some women had breast cancer. That means their descendant, okay, their child is having increased risk of getting breast cancer. It's not only breast cancer. If someone in the family had the uterus or ovary cancer as well, okay, that again also predispose the descendant, predispose the child to get a breast cancer. It's not only breast cancer in their family before, it's also about uterus or ovary cancer. When you talk about genetic factor, we say, okay, lumpy breast, dense breast. Lumpy breast means, lump. Lump means kind of mass in a particular region. So that's a lump. So lumpy breast, then dense breast. So when we talk about types of this breast tissue composition, dense breast, for example, dense breast tissue. If the patient is going under mammography screening, okay, and the patient have dense breast tissue, then there is high chance that mammography screening may miss the diagnosis, may miss the may get failed to detect the cancer, breast cancer. Okay, so what does this mean is, if the patient is having dense breast tissue, there is increased risk of breast cancer. That's what it means. Okay, and many variables including age, weight, menopausal status, hormone replacement therapy, parity, all these things we discussed, can influence mammography breast density as well. So here we are talking about breast density. So this is what's the age of the patient, what's the weight of the patient, whether the patient is having regular menstrual cycle, what is the hormone replacement, whether the patient is on hormone replacement therapy, what is the parity status. So all these can affect the mammography screening, okay, mammographic breast density. So if you see the risk, how much, if you see the if you quantify the risk, if there is any, there are any first degree relative means like your parents, like directly, okay, first degree, like if your grandparents become second degree, okay. So first degree relative have breast cancer, that increases the woman's risk of getting breast cancer of around 1.5 to 3-fold, okay. So if the risk is affected by both a woman's age and the age of relative when diagnosed. I mean, in the family, if someone is diagnosed with breast cancer, at what age they got diagnosed, and what is the woman's or the patient own age. Okay, so these two factors is considered to quantify the risk. Okay, for example, a higher relative risk is seen when a woman and her relative, woman means patient, and her relative at diagnosis are younger than 50 years. Okay, so that means if the relative in a family is less than 50 years and have diagnosis of breast cancer, and this woman whom we are suspecting, this patient, is also like at increased risk of getting breast cancer. That's what it means. If you see the second degree relative, and then it's very complex. We cannot quantify as we quantified in case of first degree, okay, 1.5 to 3-4. Okay, it's not that easy for in case of second degree to quantify. So right now we're talking about genetic, where we discussed about the familial risk, okay, the hereditary thing. Now we'll be diving a little bit into genetic part, the gene part, as it is, as we are discussing about genetic risk factor or genetic causes. Mm, so here they have the scientists have identified different gene, okay, where they are telling if the mutation is there in this so and so gene, there is high chance of getting a cancer, okay. So for example, they have isolated this BRCA1 gene, okay, in around 1994, and BRCA2 gene, okay, in the chromosome 31. And they have found that if the mutation is happening in any of these gene, the patient is high risk of getting breast cancer, okay, BRCA1 and BRCA2. These are nothing but like a tumor suppressor gene. I hope you remember from our previous class what is tumor suppressor, what is oncogene. So these are tumor suppressor gene, but if the mutation happens in this gene, then there is high chance of getting breast cancer, okay. There is, if you see the estimate, BRCA1 or BRCA mutation is estimated to be 35% to 80%, 84% of breast cancer, and 10% to 50% of ovarian cancer. Okay, so BRCA1 can also predict ovarian cancer. That's what it means. So since we know the gene, okay, we know the gene, if the mutation of that gene is there in the patient, that means we can understand, we can predict to an extent that whether this patient is risky to get the breast cancer or not, isn't it? So that means we can test a patient for this gene, okay. So but the problem is there is not clear cut guideline in what condition we should test, okay. And even after we test, when with how accurately is the prediction that how accurate is the prediction that like I mean to say, what to what extent, how can we quantify the risk of getting a breast cancer? So testing is generally recommended only when the person or the family history is suggestive of hereditary cancer, okay. So because the test alone is not sufficient to interpret adequately. Am I clear?
Yes.
Are you following me?
Yes, sir.
Yes.
So what to do with the test? Actually, generally many people after getting tested BRCA1 or BRCA2 mutation positive and having strong family history of breast cancer, they undergo mastectomy, okay. Mastectomy is a complete removal of breast, okay, complete removal of breast tissue. So they undergo mastectomy or oophorectomy. Oophorectomy is removal of ovary, so that they don't get um, the cancer in the coming years. And they also sometimes get put on chemo preventive drugs, okay, so that they don't they decrease the chance of getting a cancer. The benefit there are two drugs very commonly and very famous drugs, tamoxifen and raloxifene. Can anyone tell which class it is? We have already discussed tamoxifen and pardon?
Selective estrogen receptor modulator.
Correct. These are estrogen receptor modulator, okay. And this is interesting actually. See, when we have seen receptor antagonist, receptor agonist, but in this case we are telling receptor modulator, okay. Why do you say that modulator? Why did you say modulator? Did you ever wonder on that? Who said that? Follow me.
Yes, sir.
And why did you say modulator? Why it is not agonist or antagonist? That's what the question is. You'll get to know the reason, okay. You'll get to know the reason when we discuss about the treatment. I will explain there. It's sometimes depending on the tissue, whether it is acting in breast tissue or ovarian tissue,